exam. Okay, every NBME has a question. We need to really understand this disease. Now, when we talk about achalasia, first the definition, right? The definition is failure of lower esophageal sphincter to relax. That's a problem. So the normal function, so esophageal area, right? It's a pipe that takes the food from oral cavity to the stomach. It's one-way pipe. So it opens up the lower esophageal sphincter when we eat food, okay? And then it has to close rest of the time, so no reflex, nothing happens. Here, they don't open at all, so they're permanently closed. That's what it is, basically. So lower esophageal sphincter does not relax, okay? Now, the main key, it only affects the lower esophageal sphincter, not the entire esophageal area. That's important. Now, why that happens? Because of a degeneration of specific neurons we call nitric oxide and VIP, but especially nitric oxide. And they do not have myenteric plexus. The myenteric plexus is the problematic. If you remember, yesterday we said myenteric plexus is the nerve network that's located between those muscularis externa, right? Inner circular and outer longitudinal. So that's where the problem is. Now, what happened to submucosal plexus? It's perfect. It has nothing to do with that. It's only the myenteric plexus, okay? Myenteric plexus is affected. Because of that, they cannot open the lower esophageal sphincters. Now, there is a primary and secondary. Primary is idiopathic, which means we lose it. We don't know why we lose it. Secondary means some other disease is destroying it. A good example is a Chagas disease, Trypanosoma cruzi infection. It can come, that organism can destroy the myenteric plexus, folks, okay? So that's the idea. Now, it doesn't open, it failed to relax, and because of that, we have primary and secondary. Now, before we talk about it, look at this picture. Now, in here, this is where the lower esophageal sphincter is. Because the lower esophageal sphincter right here, it's not opening, proximal to that, it's all dilated because nothing is going down. Does that make sense, folks? Okay, so proximal to that, it's well dilated because nothing is going down, okay? Now, because of that, when you see this test, we call this bird's beak appearance, right? It looks like a bird's beak. This is what we call barium swallow, so which means we give some contrast fluid to drink, and after they drink, we scan. So then we pick this picture, folks, okay? Now, so this is completely normal. This area is completely normal. This is where the pathology is, okay? That's where the pathology is, folks, okay? Now, if you see that, it's the bird's beak appearance, barium swallow. Now, that's the initial diagnostic test. We already talked about it, right? What's the initial diagnostic test? When somebody comes with the symptoms and the first test that you do is the initial diagnostic test. Once initial diagnostic test becomes positive, then we have to do confirmatory test, isn't it, folks? The confirmatory test will be manometry. I'll just put C, okay? So that's your confirmatory test. So we cannot do manometry unless your barium swallow is positive. Does that make sense, folks? Because why? Manometry is an invasive test and is very expensive test. So we cannot do that unless you have a positive barium swallow. If you do barium swallow, everything looks normal, then you stop right there, okay? So barium swallow is the first one, and manometry is the confirmatory test. Now, the question is, what is manometry? Manometry is basically, we go to lower esophageal sphincter and measure the pressure of the sphincter. We are measuring the pressure, okay? So we are trying to measure the pressure, how much pressure they have it. So I have to go to that because they put a picture of that pressure on the exam, folks, okay? So let's say, upper esophageal area, middle esophageal area, lower esophageal area, lower esophageal sphincter. Same thing here, okay? I'm doing normal versus patient, okay? This is normal. This is achalasia. Now in normal, so let's say relaxing. So if you see here, folks, when we talk about achalasia, first of all, we should only focus lower esophageal sphincter because that's the only part affected, isn't it? Okay, so which means everything else will look perfectly normal. There won't be any problem. Only lower esophageal sphincter will be problem. Now, if you see here, this is where the pressure is dropping. When the pressure, so this is the pressure, right? So it's dropping, which means they are relaxing. This is normal. The lower esophageal sphincter is relaxing. But whereas in this patient, it will look like this. You see that? It did not reduce it. You see that? Now you could compare. Here, the pressure do not really reduce, which means they don't relax. This is how you compare for lower esophageal sphincter. Is everybody clear, folks? Okay, so I repeat, only lower esophageal sphincter is affected. Of course, we have a question in UWorld. They have a better picture. I'll show you, but that's how we diagnose it. So lower esophageal sphincter. Is everybody clear, folks? All right. Now, let's go back and I'll come to the drawing one more time. So the patient comes with progressive dysphagia. Now remember, dysphagia means difficulty swallowing. It's not painful swallowing, okay? There's two different things, folks. Sometimes when you drink water or something, whether you feel the pain or is it difficulty, two different things, okay? Now, we all had sore throat in our life. When you have a sore throat, eating or drinking fluid hurts, isn't it, folks? That's called odynophagia. Okay, that's odynophagia. What is odynophagia? Painful swallowing. That's painful, it hurts. Dysphagia means there is no pain, it's just hard to do it. It's being difficulty to do it, folks. Okay, so that's the idea here. It's to solid and liquid. That's very important. And these people have increased risk of esophageal cancer. Okay, now to recap, achalasia, the definition, lower esophageal sphincter is not relaxing, therefore they are not opening, okay? Now it could be primary or secondary. Now, if they come with the symptom, the first test we do, barium swallow. In barium swallow, if you see a bird's beak appearance, then that test is positive, then we confirm with manometry. Once manometry also confirmed, we could go for treatment, either surgery, we could do endoscopic procedure. Let's, for example, Botox injection. What does Botox do? It relaxes the muscle, isn't it, folks? Botox relaxes it, okay? Anywhere you use Botox in the muscles in the human body, it relaxes the muscle. That's all it is, folks, okay? So we could do that, different type of treatment. That is achalasia. Is everybody clear, folks? All right. Now, let's continue with the other esophageal pathology, okay? Now, since we did achalasia, I want to do GERD right after that. Gastroesophageal reflux disease. Now, this is literally opposite to achalasia. Achalasia, the problem of opening. Here, the problem of closing. Lower esophageal sphincter does not close. In GERD, lower esophageal sphincter does not close. Therefore, regurgitation happening. Heartburn and regurgitation, dysphagia. Now, I want you to write next to regurgitation, digestive regurgitation. Digestive food particles. What does that mean? Once the food is in the stomach, it's already in the acid and everything. When they come back, it's already partially digested. Is that crystal clear, folks? Because there is one more disease we will be learning. They also have regurgitation, but it's a non-digestive regurgitation. We'll talk about that, okay? So this is a digestive regurgitation. May also present as a chronic cough. Why, folks? The acid comes back and it gets into your larynx and it goes into trachea and people have a cough. Hoarseness because of the vocal cord, right? When the acid goes in the larynx, it can do that. So hoarseness. Now for the hoarseness, it's usually early morning, okay? Make sure you write it down. It's early morning hoarseness. What does that mean? When people wake up in the morning, they complain of hoarseness, but then it gets better as the day progresses. Versus you had a recurrent laryngeal nerve damage, they have hoarseness throughout the day. Remember that? During the thyroid surgery or anything, they could damage, right? So those are the two types of hoarseness. Somebody had a question?
Yes, Dr. Dr. Roy, the digestive regurgitation is once it reaches to the stomach and comes back.
Yeah.
If it's non-digestive, then it doesn't reach the stomach.
It doesn't reach the stomach. So that means the food is coming back before it reaches the stomach. Okay.
Okay, got
There
it.
is a disease. I will talk about the disease when we get to that.
And dysphagia is problem swallowing, and odonophagia is painful.
Yeah. Okay. Now.
And there's something called liquid difficulty in swallowing liquid, and then difficulty in swallowing the solid.
No, see, it's not like that, right? In the beginning, when you start swallowing, it's all about the progression, okay? When the problems start in the beginning, it's easy to swallow liquid and difficulty for solid, but then eventually, as the disease progresses, it becomes the same. That's why we don't really worry about it. That's not a differentiating factor for between diseases. So I wouldn't really worry about whether it's a difficulty to fluid or solid.
Okay. Got it. Thank you.
Now, this can also give asthma. Remember, folks, if it can goes to larynx, it can also goes to the bronchioles, right? It all the way down. So it can give you asthma. So a good differential diagnosis for asthma is a GERD, okay? If a patient says, all these symptoms are happening when I wake up in the morning, then I would consider GERD as a diagnosis, folks, okay? Now, complication include, so when people have GERD for a long time, they could get erosive esophagitis, stricture, and Barrett's esophagus. These are complications. Not everybody gets it. If they find the symptom early and they treat, they have no problem. But only complication people who ignore it, right? Some people who has a heartburn, if they ignore it for 4 or 5 years, for sure they will have Barrett's esophagus. Is that clear, folks? That's the idea. Now, treatment. I just want you guys to write this next to it. PPI makes them feel better, okay? Give them PPI, resolve the problem, okay? This is very important, folks, okay? PPI makes them better. Now, what did we say the problem in GERD? The lower esophageal sphincter is not closing, opposite to achalasia, isn't it, folks? Now, if I were to go to this drawing, all I have to do is cut this off and say this is GERD and this is normal. Do you guys agree? Because what's the problem? In normal, they are closing. These guys are not closing. Is that clear, folks? So you have to be careful, okay? It's all happening in the lower esophageal sphincter, nowhere else. Yes, I agree? All right. That's GERD. Now with this, right away, I want to go find where is next one. Let's go to esophagitis. In esophagitis, the first thing I want to talk about, eosinophilic esophagitis. Eosinophilic esophagitis is basically you are eating something that your esophageal area is allergic to that. So some food particle is causing allergy. Do you remember in respiratory hypersensitivity pneumonitis? What is hypersensitivity pneumonitis? When people inhale certain substances, right? In farmers or birds, it causes allergy. I mentioned this name at that time, right? It's basically your esophagus is allergic to some food that you eat. Infiltration of eosinophil in the esophageal or patient with atopy. Etiology is multifactorial. Food allergens, we don't know what it is. One thing I want to write next to it, PPI do not help. Because there's a question, everybody's missing this on NBME. The question looks like a GERD when you read it, but the minute they say the PPI helps, then you don't pick eosinophilic esophagitis. The only time you could pick eosinophilic esophagitis when they say the PPI did not help. If the PPI is helping, it's not allergic. Is that clear, folks? So pay attention to that. I'm going to show you that question today, okay? So that's eosinophilic esophagitis. Now, eosinophilic esophagitis is under esophagitis. Okay. Now, esophagitis is mostly a complication. We just talked about it, inflammation of esophagus. They say associated with reflux. You see, when people have an acid reflux, they could get esophagitis. Immunocompromised people can get Candida, can cause. HSV can cause. But for me, what's important? Drug-induced esophagitis. That's the most important one, which means when people take certain medication, if that medication is very acidic, it can cause esophagitis, okay? Now, especially bisphosphonate, potassium chloride, even NSAID, folks, anything, right? But both are, so anytime you prescribe bisphosphonate for osteoporosis people, right? We tell them they have to take the medication in a sitting position like this, and they have to drink a lot of water, and they also have to stay upright for minimum 30 minutes. They can't lay down because we want to make sure the medication goes straight to the stomach. If the medication is going slowly in esophageal area, it will cause esophagitis. Is that clear, folks? That's important, okay? So that's the idea. So that's esophagitis, folks, okay? Now, let's talk about esophageal varices. We should already know esophageal varices is known as dilated submucosal veins. Dilated submucosal veins. Yesterday we said just dilated submucosal veins are considered esophageal varices. Look at this picture. You could see here how those tiny veins are dilated. Okay, in your book you might see it better, but those veins are dilated. Now that's called esophageal varices. And the minute patient presents with esophageal varices, you should know there is a portal hypertension. Is that clear, folks? That's belong to portal hypertension. Okay. Now, who develops portal hypertension? Patient who has cirrhosis or who has portal vein thrombosis. I wrote that yesterday. Okay. Now, these people, what happens is once the vein keep dilating, remember there's only certain level they can dilate. What happens after that? They rupture, then they bleed. Then the blood comes from the mouth. We're going to call it hematemesis, folks. Now, you should know esophageal varices can be ruptured or non-ruptured. It depends on the severity. Does that make sense, folks? Because I know some student thinks we call it esophageal varices after it ruptured. That's wrong. As soon as the vein is dilated, we call it esophageal varices. The complication can be ruptured or non-ruptured, okay? So that's esophageal varices, folks. Is everybody clear with that? All right. Now, next, let's go to this one. Distal esophageal spasm. We used to call this diffuse esophageal spasm, and we could still call it, it's the same disease, okay? Now, what is this, folks? Diffuse esophageal spasm means the entire esophageal area is affected, which means in my drawing, upper esophagus is affected, middle is affected, lower esophagus is affected, but not lower esophageal sphincter. Lower esophageal sphincter is intact. I'm sure it says somewhere. It's spontaneous, non-peristaltic, uncoordinated contraction of the esophagus with, look at the word, highlight that, normal lower esophageal sphincter pressure. That's very important. The minute you know the lower esophageal sphincter pressure is normal, you cannot pick GERD or achalasia. Is that clear, folks? And also to diagnose diffuse esophageal spasm, lower esophageal sphincter has to be normal, okay? They could give a scenario of this question and they could ask you which of the following is normal on that patient. It's lower esophageal sphincter pressure because sphincter is different than the rest of the esophageal area, folks, okay? Presence with dysphagia. Now, the most important, these people come with the chest pain, okay? Now, when people come with the chest pain, that's right there, epigastric chest pain, okay? Same pain, chest pain. The reason is a smooth muscle spasm. Because what's the problem with diffuse esophageal spasm? It's a smooth muscle in the esophageal area is contracting. So smooth muscle spasm, and the treatment is calcium channel blocker. Okay. Now, whenever you have this, there could be two diseases. Whenever patient comes with chest pain because of a muscle spasm and we treat with calcium channel blocker, it could be two diseases. One is diffuse esophageal spasm, the one we just talked about it. Why that? Because it's a smooth muscle, isn't it? Your esophagus is made up of smooth muscle. Next, smooth muscle has calcium channel receptor. So if you give calcium channel blocker, it relaxes it, isn't it, folks? And it's in the chest area, so it's also give you chest pain. Agree? Now, they give this scenario, they ask you, what is the other disease that gives you the exact same pain and exact same treatment? Everything is exactly the same. The answer is Prinzmetal angina. What's the pathology in Prinzmetal angina? Coronary artery smooth muscle spasm, isn't it? So it's the same smooth muscle spasm. What does it give you? Same chest pain in the similar location. How do you treat? Calcium channel blocker. Is everybody clear, folks? So if a patient comes with Prinzmetal angina or diffuse esophageal spasm, I cannot differentiate that. Is that clear, folks? Because they both have the same smooth muscle problem. They both get treated with calcium channel. How do you differentiate now? Prinzmetal angina has EKG changes. Diffuse esophageal has normal EKG changes, folks. Okay. Is that clear, folks? Only EKG can be differentiated. This is a famous question. Most of the students miss. Okay, I repeat this. They both comes with the same chest pain, similar pathophysiology, which means both have smooth muscle contraction and both get treated with calcium channel blocker. If I have two patients in front of you with both disease, there is no way you could tell who's who. The only way to tell, EKG. Is everybody clear, folks? Even EKG, there's more to it. We'll talk about that in cardiology, okay? So that's the idea here, folks. Same thing, manometry is a diagnostic. Now remember, when we do manometry, these patients will have the whole esophagus affected except the lower esophageal sphincter. Is that clear, folks? I'm going to show you that soon, okay? So that's diffuse esophageal spasm. Look at that. Treatment include nitrates and calcium channel blocker. I would write next to it, Prinzmetal angina, Prinzmetal angina. So you know when you review, they both are same, folks, okay?
I have a question.
Sure.
So when you do the DES, the esophageal on the top one would be like eclasia, like smaller or something like that, or would it just not move at all?
No, they will be contracted. They will be like almost like a torturous,
Okay.
because the whole esophageal area is contracting.
So basically, when the food, if someone eats, it won't be able to come down, right?
They won't be able
No.
to even breathe at that time because of that pain. So there is no way they could eat. That pain, you know, you could create that pain. You just have to drink half a liter of extremely cold water, you will get that pain.
Okay.
Like a frozen water. If you drink that frozen water, half a liter, you will literally get that smooth muscle spasm, because extreme cold water causes smooth muscle spasm. So in that moment, nobody can even think about eating, folks. And this pain comes for a few seconds, right? The smooth muscle spasm will come for like 8 to 10 seconds and then it relaxes, right? So that's exactly what it is. So it's extreme pain. Now, next.
Sorry, one more question. Sorry, one more question. It was about the esophaguses. You said the PPI doesn't help. Does it not help for both of them, or just for the one esophagus?
So PPI helps acid reflux because it can block the acid production in the stomach.
No, for the next one.
Which one? No, it doesn't, because it's an allergy. How can a PPI help in allergy?
I know it doesn't help on the eosinophilic one, but what if it's not the eosinophilic form? It's
No,
the
I'm only
normal.
talking about eosinophilic esophagitis. If you have esophagitis due to acid reflux, then it will help.
Okay.
I'm only talking about eosinophilic esophagitis.
Okay. Thank you.
Now, next disease we're going to talk about, Mallory-Weiss syndrome, very important. Okay, now what is Mallory-Weiss syndrome? People come with partial thickness and longitudinal laceration of gastroesophageal junction. What does that mean? So let's say, this is the stomach, right? For example. So the whole story, what happens when people drink a lot of alcohol? These are alcoholics who drinks a lot of alcohol. Drinking alcohol is not the key here. They drink, but they don't eat anything after that. So they are on empty stomach. When they have alcohol in the stomach without food, that alcohol causes inflammation of this mucosa. This mucosa is very inflamed. And it makes those esophageal wall to become weak. Okay, so they are very weak. In that time, if they vomit, when they vomit, you guys all vomited once in your life. It hurts, right? Every time you vomit in your chest. Why does it hurt? Because the force, the projectile force that comes, it hurts. So what they do, the vomiting comes and it hits this lower walls and it rips the layer. Those vomiting causes the weak wall to have a little tear in that area, folks, okay? So Mallory-Weiss syndrome is a problem of mucosa and submucosa, that's it. So there's a little tear of mucosa and submucosa, okay, due to severe vomiting. Alcoholic is one example. Anorexic people can also get this. In another word, whoever does frequent vomiting can get this. Is that clear, folks? When people do frequent vomiting, can get this, is because of the force that comes. Every time we vomit, increase in intra-abdominal pressure. You should know that, increase in intra-abdominal pressure. The vomiting is done by increase in intra-abdominal pressure that comes and hit these edges. Is everybody clear, folks? So that's Mallory-Weiss syndrome, often presents with hematemesis, abdominal pain or back pain, usually found in patients with alcohol use disorder or bulimia nervosa. See, now why I keep saying alcohol? In Chicago, we see this all the time in the winter because homeless people, they drink to keep their body warm, but they don't eat. So they drink and they vomit. They drink and they vomit. They come to us with Mallory-Weiss syndrome, folks, okay? So they don't have insurance. So what happens when they come to the ER? We just treat them for what they come. Is that clear, folks? We treat them and we send them back. Then guess what? After a few times, they will come with this disease. So people who had Mallory-Weiss eventually gets Boyer-Haave syndrome. What's the difference? Boyer-Haave means entire wall has a tear. It's transmural now, which means mucosa, submucosa, muscularis externa, and connective tissue, your serosa. Is that clear, folks? That makes sense, right? You develop Mallory-Weiss. If you don't take care of it, it becomes Boyer-Haave. Is everybody clear, folks? So Boyer-Haave is a severe version of that disease. In another word, whoever gets Boyer-Haave must have had Mallory-Weiss syndrome. Is that clear, folks?
So is it considered like a complication for Mallory-Weiss?
It is not a complication. It gets progress to it if they don't treat, okay? So you kind of could say it's a complication, or, some people, if the body is really weak after one Mallory-Weiss, can directly get into Boyer-Haave, right? So it's a second step to it. So you could see that transmural, usually distal esophageal rupture due to violent retching, okay? That's Boyer-Haave syndrome. Now, let's learn about the word transmural. Transmural means it goes through the entire wall. Okay, that's what called transmural. We will use the transmural word frequently. We will use it here in cardiology and multiple places we will use. Transmural means entire thickness of the wall. I cannot call transmural for Mallory-Weiss because it's not the entire wall. It's only mucosa and submucosa. Does that make sense, folks?
Is it only the submucosa and mucosa in the stomach, or it could be the esophagus as well?
It's only in the esophageal area. This is a disorder of esophageal area. So it
No, I
only
mean, you know how you said that when you
Transmural-
vomit. No, what I mean, you know how you said when you vomit, it comes up to the esophagus.
it only happens in
right?
the esophageal area.
Okay.
Yeah,
The
because
stomach is okay.
no, yeah, the pressure only hits the esophageal junction, lower esophageal junction. That's where it happens. Okay, so that's Mallory-Weiss syndrome and esophageal perforation.
Dr. Roy,
Now-
I have a question about how we can differentiate between lower esophageal sphincter and gastroesophageal junction. I see that a lot in question stems.
Gastroesophageal junction is simply where the esophagus and stomach meets, that's all. It's a physiological junction. Lower esophageal sphincter is a sphincter right there. They
So
are
this-
next to each other.
Gastroesophageal isn't an actual structure.
No, it's not actual structure. It's just the border between esophagus and the stomach. Okay. So that's Boyer-Haave syndrome. Now remember, Boyer-Haave syndrome is coming under esophageal perforation, but this is very specific, Boyer-Haave. Now we do have other esophageal perforations. Like for example, if you see, most commonly iatrogenic following esophageal instrumentation. What does that mean? People get esophageal perforation after a procedure. People who go for endoscopy can get esophageal perforation. Okay, so those things can happen. But for somebody to develop Boyer-Haave syndrome, it's because of Mallory-Weiss. Is everybody clear, folks? Okay, so you can't say because of endoscopy now somebody had an esophageal perforation and I'm going to call Boyer-Haave. No, you could only call Boyer-Haave if they have a history of Mallory-Weiss syndrome. Is that clear, folks? All right. Now, what are the symptoms? Pneumomediastinum. What is pneumomediastinum? Pneumo mean air. Mediastinum mean air in the mediastinum. Now we studied in respiratory. Entire thoracic cavity is negative pressure, isn't it, folks? So which means now the mediastinum is getting some air. The minute you see air in the mediastinum, you should know there is a perforation of a esophageal structure, folks, okay? That's important. That's the only way to get air there because your GI tract has a lot of air. Next, subcutaneous emphysema. Now remember, this word subcutaneous, right? It's an air that gets into your skin. That's what we call subcutaneous emphysema. So from the chest area, air will go inside the skin and it become like a bubble wrap. You have seen that bubble wrap, how you pop, right? Same thing in the thoracic region. You could see the bubbles in between skin. You could literally pop those, folks. It's an extreme condition, but that's what they get. Air is getting in there, okay? Now, that's esophageal perforation and of course, Boyer-Haave syndrome. So make sure you
And
don't...
about the in the thoracic region, the pressure is always negative. So in the abdominal, it's positive.
The abdomen is negative too. There's no positive pressure in there. It's all sealed. But the thing is, in the abdomen, we don't really care about the pressure because there's no breathing involved.
Right. Okay.
Now, so those are the main diseases in this section, folks. Okay. Now let's go back to this one. Esophageal stricture. When somebody develops esophageal stricture, it's always a complication of some other diseases. Nobody developed esophageal stricture as a primary disease. So if they have that, look at this, some ingestion, acid reflux, or esophagitis, something has to cause that disease. If somebody comes with esophageal stricture, my question will be, what is the primary disease do they have or do they have? Okay, so that's the idea. Next, Plummer-Vinson syndrome. Plummer-Vinson syndrome is like a triad. Patient comes with dysphagia, iron deficiency anemia, and they also have some esophageal web. So technically, because of iron deficiency, they have some webs inside the esophageal area, folks, projections. These people have increased risk of esophageal squamous cell carcinoma associated with glossitis. Glossitis is the inflammation of the tongue, okay? So for me, the way you think, when I say, or whenever you hear Plummer-Vinson syndrome, iron deficiency anemia should come to your mind. That's the bottom line, folks, okay? So that's the idea. Now, stricture can be due to fibrosis too, okay? So what does stricture mean? Your esophagus is becoming narrowing. There is no elasticity. Is that clear, folks? So technically, it's a fibrotic at that point. Yeah. Now, that's Plummer-Vinson syndrome, folks. Last one, scleroderma. Scleroderma is another disease. It's a part of the Crush syndrome, right? Crush syndrome is a complex of 5 diseases. The E stand for the esophageal dysmotility. That's the idea. You have esophageal smooth muscle atrophy, decreased lower esophageal sphincter pressure, and distal esophageal dysmotility. So which basically GERD, these people develop GERD here, folks, okay? The minute that involve lower esophageal sphincter, they develop GERD and stricture. It's all complication, folks, okay? Scleroderma can give all the complication. So scleroderma and acid reflux will have similar manometry finding. Is everybody clear, folks? That's important. So these are esophageal disorders. Now, before we go further, let's try a question. I want you guys to give me, okay, let's see here. All right, go for it. Mute your mic, please. Don't need to read this question to answer, but this 43-year-old man is evaluated for retrosternal discomfort and dysphagia for the past several months. He smokes a pack of cigarettes daily and drinks alcohol on weekends. BMI 32. Physical exam is unremarkable. So another word, this vignette doesn't tell anything, folks, technically. Okay. You need to look at the drawing. Look at this drawing, normal versus patient. And when I look at pharynx is normal, upper esophageal sphincter is normal, upper esophagus middle, all good looks. But look at this lower esophageal sphincter. When lower esophageal sphincter is relaxing right here, going so down, this patient's sphincter is not relaxing. See, the pressure is so high, it's right on the top. The pressure is at almost 70 to 80. Does that make sense, folks? 70 to 80 millimeters of mercury, whereas in a normal patient, it reaching 0. Do you see that, folks? When a normal patient's reaching 0, this guy is not relaxing. So I could tell by looking at lower esophageal sphincter is not relaxing in this patient. That makes achalasia as a diagnosis.
Doctor, so does the amplitude of the waves not matter?
Not matter. You just look at the number.
Okay.
Okay. So that's achalasia. Now that's the key. Okay, so that's how you do it. Now, if you see the options here, right? So you have achalasia, that's the answer. If you think it's a diffuse esophageal spasm, the lower esophageal sphincter should be perfectly normal and it should only affect the upper middle lower esophagus. Is that clear, folks? Okay, now I'll show you a picture here. They're gonna compare everything. Look at that. If you see this picture, it shows normal versus all the disease. Look at the lower esophageal, the diffuse esophageal spasm. Everything is involved. The whole esophagus is involved except lower esophageal sphincter looks perfectly normal. You see that, folks? Okay. Now, when you do this question, take a screenshot of this and add to your book or wherever the section is. This is very interesting. Okay, so that's the idea. So that's achalasia, folks. This is what the manometric test looks like. Is everybody clear here, folks? Okay. All right, let's see this question. 53-year-old man comes with nocturnal cough. That means the coughing only in the night, okay? Undergoes upper endoscopy with esophageal biopsy, which makes sense because if they have a cough only in the night, two diagnoses, GERD or postnasal drip, okay? These are the two things that we possibly think. Light microscopy of the tissue specimen shows elongation of lamina propria papillae with several eosinophil and neutrophil. Now, I know some of you guys going to look at this one line and make a diagnosis. You cannot, okay? It's eosinophil and neutrophils. They both are there. The patient takes metformin and enalapril for the diabetes and things. Okay, now he started on pantoprazole. What is pantoprazole? It's a PPI. After 2 weeks, the symptom resolve. That gives you the diagnosis. You take a PPI, symptom resolves. Simple, it's GERD. How many times I told you when you take a PPI, if the symptom resolve, it cannot be eosinophilic esophagitis. It cannot be. Because if you think eosinophilic esophagitis, PPI should not help. Is that clear, folks? It's allergy. Okay, so here it's a GERD. What is the GERD? Gastroesophageal junction incompetence. Okay, so that's the lower esophageal sphincter. It's not closing, folks. That's the diagnosis. Now, I know some people fell for metformin and enalapril. Metformin and enalapril is pill-induced esophageal mucosa damage. That's not a drug-induced esophagitis, folks. Okay, that's not a drug-induced esophagitis. And even if you think, let's say you have a drug-induced esophagitis, would the PPI help? Come on. So you have it in front of it, okay? So that's the idea here. Here, in my opinion, you should be fighting between B and C, and then you rule out B because PPI gets better. Okay, that's the idea. Somebody had a question.
Yes, about nocturnal cough, what's the two diagnosis?
It's a GERD or postnasal drip. You know, sometimes people have a secretion comes from the nasal cavity when you lay down. It's more common in kids, but it can also cough, postnasal drip, okay? So what happens is a lot of secretion from the nasal cavity goes when they lay down, and it goes and create them to cough. All right, one more. I want the diagnosis. A 35-year-old man with a history of alcohol use disorder is brought to the ER with hematemesis. Prior to this, he had 3 episodes of vomiting. He has no jaundice, lungs are clear, abdomen is soft, non-tender, non-distended. There is no hepatomegaly. Endoscopy shows longitudinal mucosal tear. That word gives you the diagnosis. That's a Mallory-Weiss syndrome. Did we get that? That's a Mallory-Weiss. This patient's condition is most likely related to which of the following? So they're asking what initiates Mallory-Weiss. I ask you guys to write it down. Intra-abdominal pressure that causes the vomiting, okay? Nothing else here, folks, okay? Sometime if you think it's a venous pressure, for example, if you think the patient has portal hypertension, hepatomegaly should be there, but there is no hepatomegaly, okay? That's how we rule out that part there. All right, so that's intra-abdominal pressure is the main reason for this one, folks, okay? All right, so that's for the esophageal area. All right, let's go here. Barrett's esophagus. We talked about this on the first day. I said this is one of the best example for metaplasia. What is metaplasia? One epithelium is replaced by another epithelium that you can identify, isn't it, folks? So here what's happening, you have a squamous epithelium, okay? So you have a squamous epithelium, that's a normal epithelium. It's been replaced with columnar. Squamous is replaced by columnar. That's the bottom line, folks. In the distal esophageal area. Now, I know I skipped the second line. I'm going to explain that. So when the squamous is replaced, right, by columnar. So your normal epithelium is a squamous epithelium, which is your non-keratinized stratified squamous. Now it's being replaced with columnar. Columnar epithelium can be coming from stomach or intestine. So the metaplasia can happen from the stomach or intestine. They both have columnar. How do we know when you look at the histology, whether it's coming from stomach or intestine? If the columnar has also goblet cells, then you know it's from intestine. If you don't see a goblet cells, just columnar cells, then it's stomach. Does that make sense, folks? So finding the goblet cells is the differentiating factor between the intestine and stomach. Now, if you see here, squamous epithelium with intestinal epithelium, look at that, non-ciliated columnar with goblet cells. You see that? So goblet cells are found only in the intestine. It's not found in the stomach. Is everybody clear, folks? Okay. Now that's how we differentiate. So again, I recap. Whenever the metaplasia happens, that metaplasia can come from the stomach or intestine. The only way to tell where it came from is by looking at the goblet cells. Is that clear, folks? All right. Now, it happens due to GERD. We already talked about it, right? So when people have a GERD and if they don't treat for 5 years, it will happen, okay? Now, after Barrett's esophagus, if they still don't do anything for another 5 years, they have esophageal adenocarcinoma. Because why adenocarcinoma? It's because now it's a columnar cells. Because of a columnar cell, it has to be adenocarcinoma. Is that clear, folks? All right. So that's Barrett's esophagus, okay? Now, let's take a look at the esophageal cancer.
Doctor, may I ask a quick question? Why would it also be intestinal? Like I understand stomach because the acid from the stomach and the stomach is next to the esophagus, but how could it be intestinal as well?
Sometimes intestine has a regurgitation also, so they can spread from intestine. We don't have an explanation why, but it can happen. Yeah.
Thank you.
Okay. Now, when it comes to esophageal cancer, the upper 2/3 is squamous cell carcinoma. Lower 1/3 is adenocarcinoma. Why lower 1/3 is adenocarcinoma? Because you already have metaplasia of columnar epithelium. Okay, so that's the idea, folks. You could see that. That's a common one in the United States. So you have a higher chance to get the question on adenocarcinoma because it happens more in the country. Okay, GERD, Barrett's esophagus, obesity, tobacco smoking, all these things, folks. But when it comes to worldwide, it's squamous cell carcinoma. Okay, and that's because of alcohol, hot liquids, and other conditions, folks. Okay, so upper 2/3 squamous cell, lower 1/3 adenocarcinoma, folks. Okay, that's your esophageal cancer. Is everybody clear? So that concludes all the disorders of esophagus. So now we are done with that. We are moving to stomach. In the stomach, we're going to talk about gastritis. Now it's going to get a little complicated. So focus and listen and take notes. It's very important. Okay, it's going to get complicated.
Dr. Roy, did we do something about achalasia, like on page 385 today?
What do you mean 385?
I was trying to.
We talked about achalasia. You were not there?
No, I was there. The previous one, like oral pathology.
No, we did not. No.
Okay.
I didn't do it.
Thank you.
All right. Now, gastritis. When you go to gastritis, folks, it's a problem of the stomach. they have two type of gastritis, acute and chronic. This is very important, folks, okay? Acute and chronic. When it comes to acute gastritis, there's erosions are there. It happens quickly. There's erosion, okay? Now, when it comes to erosion, which means it's damaging the mucosa of the stomach, folks, most commonly it happens due to medications. Now, what does that mean? There's a special prostaglandin we call PGE2. These are located on the stomach. What they do, the PGE2, they produce a specific mucus of biofilm. It protects the stomach. So right now, your stomach is protected because we all have that PGE2 that secretes certain material that protects the stomach lining, okay? Now, when people take NSAIDs regularly, who takes NSAIDs regularly? People with osteoarthritis or headache, right? Osteoarthritis and headache people, they take it frequently. When they take NSAID, what is your medication is doing? It's inhibiting that PGE2, right? When they inhibit the PGE2, there is no protection. So decreased gastric mucosa protection. So that means now the acid can go and damage the mucosa directly. Is that clear, folks? Mucosa directly. Like think in this way, right? So let's say this is your epithelium of the mucosa. And then you have, this is that PGE2 protective layer, okay? And you have your H+ acids here. For example, this acid cannot reach epithelium because that protective layer is there. When people take NSAID, there is no protective layer, simply mucosa. So the acid can go and damage. Is that clear, folks? Okay. Now, if you take NSAID for a week, would that happen? No, you have to take it for a longer time, okay? Now, that's why most of the time, if you have to take for a week or two of a strong dose of NSAID, they also give you PPI, isn't it, folks? That's because when they want to give it, they also want to block the H+. So to protect it, folks, because sometimes you have to take a really high dose. Then they have to take PPI that can protect. That's a medication-induced or drug-induced acute gastritis. Is everybody clear, folks? Okay, now that's pretty common in US. Why? A lot of people have osteoarthritis and it's pain and they have to take it. They take it almost every other day, 800 milligrams. That's a high dose. And migraine, right? So that's that. Next, burn ulcer, we call curly ulcer.
Dr. Roy, do we prescribe the PPI to everyone, or there are few people who don't get affected?
No, see, usually if they are taking NSAID for less than 5-6 days, we don't, okay? But if it is more than that, then we give it. And it also depends on the patient's condition. If they have a pre-existing history that they took a lot of NSAID, we give it. And it also depends on the doctor. Some doctors give it for even 3 days, they say to take PPI. Some people don't. Would I give it? No, I won't give it PPI at all, even for 2-3 weeks, right? It depends on the person. So that's individual basis. So we're not gonna, ask them the question, will they give it? But I'm just saying it, how that can be protected on that. Okay. Now, Burns ulcer. This is important. What is Burns ulcer? When somebody get burned, right? What do the first thing happen? They lose the fluid, isn't it? Burns causes hypovolemia because they lose the fluid. When they lose the fluid, folks, technically they are also losing blood. Now they have less blood to send it to stomach. And when there's a less blood, hypoxia. Hypoxia gives you ischemia. Is everybody clear, folks? Now we said it, right? Hypoxemia causes hypoxia. Hypoxia causes ischemia. Ischemia causes infarction. Infarction causes necrosis. So here we call it curling ulcer is because simply due to burn, they lost blood. Is everybody clear, folks? All right. Now, next, Cushing ulcer. I'm going to highlight that, folks, okay? This is important also, not easy to pick it. There was a question on NBME. I almost lost that question when I did it. I'll tell you why. So brain injury, okay? Now what's going to happen is, let's write this separately. So patient had a brain injury, okay? Patient had a brain injury and went to coma. So when patient had a brain injury and went to coma, they are unconscious. They cannot talk, they cannot feel nothing. Is everybody clear, folks? Okay. Now, when they are in coma, do we feed them? Yes or no? We do feed them, but how do we feed them? We feed them through TPN, total parental nutrition, through IV line. Is that clear, folks? All right. Now, anytime there is a brain injury, that brain injury overstimulates vagal nerve. So every time there is a brain injury, they overstimulate the vagal nerve. And we know vagal nerve goes to parietal cell, and parietal cell secretes H+. Is that clear, folks? Now think about it. This patient is unconscious and don't eat food orally, but her or his stomach is full of H+. Is that clear, folks? They could get gastritis, ulcer, perforation. Would they complain? They cannot complain because they are in coma. Is that clear, folks? That's called Cushing ulcer. Okay. Now, because of this, whenever patient had a brain injury and they go to coma, we know they're going to produce high H+ and they cannot complain. We always add PPI to this IV. We always add PPI to that because they would not complain. So the question that I came across, they gave this condition. I couldn't pick it up as this disease. Okay, I did not pick it as a Cushing ulcer. They said, which of the following medication should be added to the existing regimen? I looked at all the medication. 5 of them were neurological drugs. 1 was omeprazole. The only reason I suspected it's an omeprazole because it didn't match with the rest of the option. Okay. So then I thought, why did they give? Then it clicked, but it is not easy to pick that, folks. Cushing ulcer people should be on PPI 24/7. Is that clear, folks? Now remember, for that, you need to understand what is Cushing. I would recommend you write this down so you know the whole pathway, folks, that section.
Is there a relationship to like Cushing disease, syndrome,
No,
anything?
it's not.
Okay.
Well, you could relate it. If they are in coma, they're going to be stressed and they have more cortisol. Okay, so that's the Cushing's ulcer. I'll tell you guys, it looks so easy now, but when you are doing a question, you won't even think about this. Okay, so they would never use that word. You have to be very careful to pick that. Okay, so that's acute gastritis, folks. Okay, now you could see something on the side, especially common among people with alcohol use disorder who takes daily NSAID, and and that's the idea for the acute gastritis. Is everybody clear with acute gastritis? Okay, now acute gastritis is easy. Now we're going to move to chronic gastritis. Okay, chronic gastritis is completely opposite, non-erosive. There is no erosion, mucosal inflammation there, but often leading to atrophy. You could see that. There's all atrophy. Hypochlorohydria, that means decrease H+. Decrease H+. You should know if the parietal cell has decreased H+, negative feedback causes increased gastrin because gastrin stimulate parietal cell to produce H+, isn't it? We studied yesterday. That's why they have hypergastrinemia. Everybody type, who inhibit gastrin? Just the word. Who inhibit gastrin? Everybody's going to somatostatin because it's negative Nancy. A logic answer, but the answer is secretin. Okay. Technically, theoretically, you could argue somatostatin should also do it, but specifically for gastrin, secretin. Okay, just to recall that. Okay. Now, let's see what's other two type. Look at this one, folks. I'm going to start with the autoimmune disease first. What is happening here? We are making antibodies against hydrogen potassium ATP channel on the parietal cell. So there is an antibody coming and attacking parietal cell. So what do we call that antibody? Antiparietal antibodies, okay? Antiparietal antibodies. Now this antibody is attacking the parietal cell. Can you produce H+? No. No H+, no intrinsic factor. That's why they have increased risk of pernicious anemia. Pernicious anemia is defined as B12 deficiency due to intrinsic factor. Okay, B12 deficiency due to intrinsic factor, because we need intrinsic factor in order to absorb B12, folks. Okay, so here antibody is attacking, folks. Okay, most commonly it can affect the body or fundus of the stomach. That's the idea here, folks. Okay, antibody is attacking the cells. Okay, so that's one. Now let's talk about H. pylori. That's the most common one, folks. It's an infection. Okay, now let's start writing. Listen to me first, and I'll give you the time, then you write, because it took a while to get this to understand, folks, okay? Now, when H. pylori comes, the infection get to the stomach. They could go to two locations. They could go to antrum of the stomach, or they could go to the body of the stomach. Okay, two different locations. Is everybody clear, folks? They could go to antrum of the stomach or body of the stomach. When they come to antrum, what they do in antrum, it goes to antrum D cells. Type it up. What do we secrete in D cells? I'm asking this because I want to make sure you guys remember from yesterday. Because if you don't remember, there's no point of me teaching this today. What is D cell secretes? Don't look at the book. Don't use your superior oblique muscle. Look at me. Somatostatin. Okay. So D cells, so H. pylori goes to antrum and inhibit the D cells. So no somatostatin. Is everybody clear, folks? No somatostatin. Okay. Now, stop there. Don't write this. Watch me carefully. Normally what happened, you have somatostatin. That somatostatin inhibit gastrin. Okay. That's a normal healthy people. That's normal stat. Somatostatin inhibits gastrin. Because now there is no somatostatin, you are overproducing gastrin because there is no inhibiting factor. Is everybody clear, folks? This gastrin will stimulate H+. Is everybody clear? That gastrin stimulate H+. That H+, because of the gravity, will go down all the way to duodenum. That H+ will go to duodenum. In duodenum, two things are happening. H+ is there. Now it's more acidic environment. Yesterday we studied duodenum is alkaline environment, isn't it, folks? The same H. pylori, I'm going to put a different arrow here. The same H. pylori also inhibits bicarbonate in the duodenum. They inhibit the bicarbonate and they're bringing in more H+. So patient develop duodenal ulcer. Patient develop duodenal ulcer. This is the whole step how H. pylori causes duodenal ulcer. Okay, this is the whole step. I know you might have some question. Keep your question until I finish because it will answer in this next part. So let me recap. H. pylori come to the antrum. Antrum, they inhibit the D cells, so no more somatostatin. So there's nobody to inhibit gastrin. So gastrin overproduce, that's overstimulate H+. The H+ gravity will go down to the stomach, duodenum, and it causes duodenal ulcer. Is that clear, folks? Now, if H. pylori goes to body instead of antrum to body, they directly involve with parietal cell and they cause gastric ulcer. Okay, now what is the bottom line that you're going to learn? H. pylori can cause duodenal ulcer or gastric ulcer, which we call peptic ulcer disease. Now, it's all about where they go first. If they go to antrum, you get duodenal ulcer. If they get to body, you get gastric ulcer. Is everybody clear, folks? So when you read a question, your focus should be where exactly the H. pylori went first. Is everybody clear, folks? Now, if you see the book, it affects antrum first. Then you should know it's a duodenal ulcer, and then spread to the body of the stomach, then gastric ulcer. Is everybody clear, folks? So when you're reading H. pylori question, see where they go first. Okay, they ask that. Okay, so now you could go ahead and write this down in nicely, folks.
So, gastrin is also inhibited by secretin. So is that inhibit too?
Say it again.
Is that not working too?
I can't hear you.
Gastrin is inhibited by secretin, right?
Yeah.
So because it's only blocking B cell,
Yeah.
is it also blocking?
Only blocking. No, it's
secretin?
only blocking B cells.
So is that not working too to reduce gastrin?
No. So here, what happened? Your D cells are destroyed, so there's no somatostatin, and because of that, your gastrin is high.
I know,
Don't-
but what I mean,
Don't
the,
think secretin here. Secretin has no role here.
so that's what I'm asking. Isn't secretin not working to lower the gastrin?
No, they're not. It's not enough to lower it. Yeah. Secretin can inhibit gastrin when the gastrin at a normal level, not when they're overproducing.
I thought duodenal ulcers had increased bicarbonate.
Where?
No, I thought that duodenal ulcers increased bicarbonate.
Yeah, but that's why we said H. pylori is inhibiting that bicarbonate.
And then
So
the next feedback.
No, the normal production is producing more bicarbonate. That is disturbed here.
But then how would that cause a duodenal ulcer if
So in healthy people, we produce a lot of bicarbonate, so that makes it alkaline environment. Agree?
right?
So here, that bicarbonate is inhibited. So there is no more alkaline environment. It's an acidic environment.
Okay.
Okay. So your confusion is bicarbonate protects the duodenum, and here there is no bicarbonate. That's why it's not able to protect it.
Because it's directly inhibiting the bicarb.
The H. pylori is directly inhibiting the bicarbonate by Brunner's gland. No more bicarbonate in this particular case.
Okay.
Yeah. So usually bicarbonate is alkaline. So they are in healthy people, we have enough bicarbonate. That's why it's alkaline. If you're alkaline, you cannot cause any diseases. But when you have H. pylori in the antrum, it also goes and inhibit the bicarbonate. So there is no alkaline, now it's acidic.
And that would
Everybody-
be the duodenal ulcer.
That's leads to duodenal ulcer, yes. Is everybody clear with this, folks? Anybody don't understand this?
One more question. The bicarb inhibition happened after the H. pylori go through the whole process for the
It can happen at a similar time. When they are
Okay,
doing
good.
in there, they could happen. See, let's say H. pylori is working on the antrum, they could also send to inhibit. So at the end of the day, it's your question. It's not easy to say when it happened, but we know it's all happens simultaneously when the disease comes.
No, what I meant, like, it's happened when it already damaged the duodenum, No?
No, in order to, you have to inhibit bicarbonate for you to get the acidic environment. Then you get the acidic environment that causes the damage. Yeah. All right. Let's do some question here. Let's see. So let's see here. Researchers studying GI pathophysiology analyzed hundreds of gastric mucosa biopsy specimens taken from patients who underwent endoscopy at the local tertiary care center. They noticed that colonization of the gastric antrum with S-shaped gram-negative bacteria, what's that? H. pylori. Okay. And decreased number of somatostatin producing antral cells. That means decreased B cells. Is that clear, folks? Now, if I ask you, where did this H. pylori affect first, antrum or body? In the antrum, right? If it affects the antrum, what type of ulcer do you get? Duodenal ulcer. You know the pathway, how it works, right? That's exactly what they're asking. Depletion of these cells from the gastric antrum is most likely to cause what? You should be fighting between these two, B and D here. And the answer is B because it happened in the antrum. If this question says it happened in the body, then you could go for D. Is that clear, folks? Okay. Now, you see, this is a picture that I gave you guys already. When it affects the antrum, it decreases the somatostatin production cells. That causes increase in gastrin. That gastrin increases H+. Gravity take it to the duodenum and it causes duodenal ulcer. Is that clear, folks? So now let's take a look at the body. Where is it? Look at this. In contrast, gastric ulcers occurs when H. pylori colonize the gastric body. Is that clear, folks? If you understand those two things, what I wrote, you would not have any problem here. Is everybody clear? So the antrum and stuff. And of course, when you review this question today, you're going to read it very clearly and line by line. It should make sense. Any question for me in here? Everybody understood? All right, let's go here. All right, let's see here. 35-year-old woman comes to the office due to malaise and generalized weakness. The patient has type 1 diabetes and hypothyroidism, which she takes insulin and levothyroxine. Okay. She eats a balanced diabetic diet and exercise 5 times a week, and she has mild conjunctival pallor. Okay, that's fine. But my question to you guys here, conjunctival pallor means anemia, isn't it? How do you connect anemia with her hypothyroidism and type 1 diabetes? Why? Type 1 diabetes, is that autoimmune disease or no? Yes or no? It's autoimmune disease, right? Okay. Hypothyroidism in US, yes, because Hashimoto is the most common in US, which is autoimmune. So we studied in endo, if a patient has one autoimmune disease, they could get another autoimmune disease, isn't it? So here, why do you think this person has anemia? That's pernicious anemia, right? That's a pernicious anemia. Hemoglobin decrease, mean corpuscle 118. If you see here, B12 is decreased, isn't it, folks? So literally, you have pernicious anemia. That means you have antibody against parietal cells. So how do we work on this? If you have antibody against a parietal cell, what happened to parietal cell, first of all? Is it working or not working? It's destroyed, right? If parietal cell is destroyed, what happened to gastrin, up or down? Why would gastrin go down if a parietal cell is destroyed? If the parietal cell is destroyed, the negative feedback should be high gastrin, because gastrin stimulate parietal cell to produce H+. If there is no H+, gastrin should keep going up to stimulate, isn't it? So I'm going to look for gastrin. I'm going to rule out these two options. Is that clear, folks? So you have A, B, C. Next, if there is no parietal cell, what happened to pH? Is it acidic pH or alkaline pH? It should be alkaline because there is no H+. So it should be increased pH. So I rule out C. Now you have A and B as an answer. The only way to get the answer by knowing gastric parietal cell mass, that means how big the cell is. When antibody attack, the cell is damaged, is B. Okay, B is the right answer, folks. So go to pernicious anemia in your first aid and write all those 3 things, arrow up, arrow down, because 100% you're going to get a question list on the exam. Okay, so that's the answer. Anybody didn't understand this?
Yeah, I have a question.
Sure.
Because the gastrin releases hydrogen, which would theoretically cause a acidic pH. So is
What
it just
happens?
not
Yeah, so gastrin
acidic enough?
stimulate the parietal cell. That parietal cell secrete H+, right?
But don't the G cells also secrete hydrogen?
Who?
The G cells from gastrin? Because at least that's what it says in first aid, which is why.
No, you need parietal cell to produce H+. Only that
Okay.
H+ can maintain that much acidic environment.
Got it. Okay, so it's just not significant enough.
No.
Okay, thank you.
Yeah. And Aliza, you had a question? Are you going to ask me why gastrin is increased? What's the question?
So I'm just confused with the gastrin, like why did it, obviously. I mean, I get it that the parietal cell, but I thought it would go down.
It won't. So what's the function of gastrin?
What do you mean, like the function?
What's the
of
function of gastrin? What does gastrin do?
it produces?
Produce what? See, that's a problem. You don't remember the physiology. Gastrin stimulate parietal cell to produce H+, right?
Yeah.
If there is no parietal cell producing H+, what happened to gastrin? Negative feedback should be increased.
Yeah, that's what I'm saying. If there's no parietal, then the gastrin should go down too. No?
No, why? You can't make up a rule, right? So when, let's go back to endocrine. Cortisol, who stimulates cortisol?
It's,
ACTH, right?
yeah,
If there is no cortisol, what happened to ACTH?
increase.
It increase or decrease?
If there's no cortisol, it decreases.
If there is no cortisol, ACTH increases. Always remember, the guy who regulates goes up when there is no response. Okay, ACTH stimulate the adrenal gland to produce cortisol. When they don't see enough cortisol, they're going to respond more. And
No, so the reason I'm confused, you know how they have the negative feedback?
okay.
So if there's no parietal cell forming, then shouldn't it be like stopping the gastrin to produce?
No, it cannot. No, it doesn't work like that because gastrin is functioning 100% perfect here. So when parietal cell is not secreting H+, gastrin is not getting its response, what they want. Gastrin has to see H+. When they don't see H+, they're going to keep stimulating more and more, right? Now, that's why even in the book, remember, you have hypergastrinemia, right? That's exactly what it is.
So there's no negative feedback in this thing, right? Okay.
The negative feedback is increasing the gastrin. They are not inhibiting the gastrin. So there is no negative feedback. That's correct. There is no negative feedback to get that. So that's why gastrin, the only time gastrin will go down if the parietal cell produces H+. Okay. Now, since we got that question for B, I want everybody to answer when A is the right answer. What's the difference between A? The only problem is increased parietal cell mass. This was on the exam. Type it up. You know, human psychology says whenever you pick an answer, you stick to it. Don't change it. First is always right. So here, if you see A, increased gastrin, increased gastric pH, that means still alkaline pH. Does that make sense, folks? The only different gastric parietal cell mass is increased. Does that make sense, folks? That's happened when people take PPI, proton pump inhibitors. When you take proton pump inhibitor, what proton pump inhibitor does, it closes the door. If it just closes the door, gastrin is going to keep stimulating. The cell is getting bigger and bigger because they are not releasing anything outside. They're accumulating everything inside. Is that clear, folks? So write this down, A, and all the arrow up and down for PPI. And I'll come to Zollinger-Ellison vein. I'm coming to that. Okay.
Can you explain the PPI thing one more time?
PPI blocked the parietal cell channel, but it didn't damage the cell. It just closes the door. When they close the door, still no H+, but gastrin is keep stimulating, so your parietal cell kind of become hypertrophic.
What about when you have a cancer or something?
What cancer?
You know, like you know how we talked about the bed esophagus, how to change it. Would that be?
Only
if
cancer.
If we have something, would it increase the parietal cell mass or would it decrease the parietal?
No, cancer should not affect on that. The only cancer that can affect, I know where you're going, it's Zollinger-Ellison syndrome. Okay, I'm going to come to that once they write down A. Copy that down. Did you guys copy it? We didn't study Zollinger-Ellison, but we could kind of talk. What's a problem with Zollinger-Ellison? Hypergastrinemia, right? They produce excess amount of gastrin. What does that gastrin do? That gastrin should stimulate parietal cell. Parietal cell get more H+. If the parietal cell get more H+, what happened to pH? That's where you guys went wrong when we picked A. A is almost right for Zollinger-Ellison except the pH. pH should be down, so that's your C. Is that clear, folks? C is the answer for Zollinger-Ellison syndrome, folks. Let's click. Let's make sure, yeah, you see that? That's a gastrinoma. So when people have Zollinger-Ellison syndrome, they are producing so much of H+. Overproducing, that should be acidic pH, folks. Okay, so the only difference between A and C is the pH that makes the whole thing. A, B, C, you should be able to get that answer in and out, folks. You should know in and out today, okay? It's okay if you don't know it, but now we learned it, A, B, C. This arrow up and down, you cannot miss it, folks, okay? Is everybody clear, folks? All right, let's go back. Okay. Read this and tell me the diagnosis. Let's take a look at this. 67-year-old man comes to the emergency department due to progressive fever and lethargy. The patient has also had severe right shoulder and abdominal pain, okay? Vomiting for the past 2 days. He had an appendectomy during childhood, so that's ignoring. He has no other medical problems, takes no medicine. The patient doesn't use tobacco, but drinks alcohol on occasion and occasional beer. Fever, blood pressure is kind of low. Abdominal exam shows generalized tenderness with rebound tenderness. Right shoulder examination is normal. Upright chest X-ray is shown here. Now, what do you see here in this X-ray? Oh, you know what? We haven't covered this section yet, but you should know, I forgot. But you should be able to, what do you see abnormal in this X-ray? At least tell me that. I'm about to cover this, but I forgot. I thought I covered. Okay. Now, what you see here, you see my arrow right here? You should never see air under the diaphragm. You should never see air under the diaphragm. That means seeing black color between the diaphragm and liver is pathology. Is that clear, folks? Anytime you see air under the diaphragm, it tells you pneumoperitoneum. That means air under the diaphragm is called pneumoperitoneum. For you to get pneumoperitoneum, there must be one of the GI organ in the abdominal cavity is ruptured or has a hole that leaking air. Is that clear, folks? That means the answer is perforated viscous. Viscous mean organ. Perforated mean it has a hole. Is that clear, folks? That's that. So that's what you pick here. This is a pneumoperitoneum. That's the only thing you could pick it in this picture. Because this question is a vague, it doesn't tell you anything. But that's a picture, okay? That's a pneumoperitoneum. Pneumoperitoneum. We're going to talk about right now. All right, let's go to that. Let's continue.
If there's an obstruction, and then what if the small bowel enters?
Small bowel obstruction does not necessarily is perforation. It's just a blockage.
Okay.
And we'll talk in the small intestine, okay? Now, if you see here, where did we go? We're going to come to that, folks, okay? Let me finish this. You know what? Let me do that here part. You see in this picture? Now, when you see this X-ray, this is better X-ray. That's a diaphragm. That's a liver. And you see how air in between? That's pneumoperitoneum, okay? Now, the minute you see a pneumoperitoneum, it tells you there's a perforation in the organ, folks. It tells perforation, okay? Now, anterior duodenal ulcer can perforate or any of these organs. See, that's why even the answer on that question is a perforated organ. They didn't tell which organ because we cannot tell which one. Any organ in the abdominal cavity can have a perforation and the air will leak. Is everybody clear, folks? All right, so that's a perforation part, okay? Now, since we talked about this, let's talk here. Peptic ulcer disease, we just talked, right? Peptic ulcer disease has two types, gastric ulcer and duodenal ulcer. Now, when we say gastric ulcer, it's happened in the stomach, closer to minor curvature, right? It's happening minor curvature. It says can be greater with meal, the pain. So what happened? You have a wound in your stomach. Ulcer mean wound. Is that clear, folks? Every time you eat, H+ secretes. That H+ touches the wound and it hurts so bad. That pain is like almost like a heart attack pain, folks. It hurts chest. Some people cannot even breathe. Okay, so that's pain increases with food intake. So because of that, they are scared to eat because if they eat, they get the pain, so they lose weight. Is that clear, folks? 70% is due to H. pylori infection. Decreased mucosal protection against the gastric acid. That's the idea. Other causes, drug-induced, NSAID. Increased risk of carcinoma, folks, okay? Now, comparing that to duodenal ulcer is completely opposite. Every time they eat, they feel better. Why is that? Every time they eat, in the duodenum, they secrete secretin. That secretin stimulate bicarbonate. That bicarbonate make it more alkaline. It's like more cooling. Is that clear, folks? So that cooling makes them feel better, so they keep eating. So that's weight gain. Okay, I have a gastric ulcer. Only question I had was, I'm not saying I shouldn't deserve, but I should have got the other one so I could eat. But this one hurts when you eat, yes. That's how I know the pain. It's like a chest pain, literally a heart attack every time you had that wound attack comes, right? 90% H. pylori infection. So you should know, for you to get a duodenal ulcer, where should H. pylori infect? Antrum of the stomach. Is that clear, folks? You cannot forget that today, okay? Antrum of the stomach. Decreased mucosal protection or increased gastric acid, Zollinger-Ellison syndrome can cause. It's benign, not routinely biopsied, okay? So that's your peptic ulcer disease. There's a two type. Is everybody clear with that? Now, let's go to hemorrhage. These peptic ulcer disease can bleed. Now you see in gastric and duodenum, both you can bleed. When it comes to duodenum, posterior wall is the most common that they bleed from. If you know it's a posterior wall, what's the blood vessel right behind the posterior wall? Type it up. Type it up. What's the name of the artery that's right behind the posterior wall of the duodenum? And also type it up, that artery is a branch from? What punishment should I give people who cannot recall the artery? It's a gastroduodenal artery, branch of proper hepatic artery, which is a branch of celiac trunk, right? Left gastric artery is for gastric ulcer, not for duodenal ulcer. Is that clear, folks? Okay, so right hand, get a tattoo, gastroduodenum. Left hand, get a tattoo, left gastric artery, okay? Now, if you see here, folks, ulcer on the posterior wall of the duodenum, bleeding from gastroduodenal artery. If you have a laser curvature of the stomach, bleeding from left gastric artery. We should know that from yesterday itself. Okay, so it's two, very careful. If your diagnosis is wrong, you will pick the wrong artery. Okay, I was told sometimes they actually give the angiogram of the blood vessels and they ask you to pick which artery actually. So you need to identify where that artery is. Easy, identify duodenum and you know what's behind it, isn't it, folks? So that's careful. When it comes to obstruction, blocking, pyloric is more common than the duodenum, not important. Remember this and perforation. Those are the two important things, folks. Is everybody clear? All right. Now, the punishment for not remembering the blood vessel, no break for a while. Let's go. Menetrius disease. Now, Menetrius disease is another disease. Don't get confused. The one happens in the ear. That's Meniere's disease. It's similar spellings, okay? When you read it, you have to be careful. In this particular disease, hyperplasia of the gastric mucosa. Your gastric mucosa is hyperplasia and hypertrophy drugae, right? Look at this picture. Look at the stomach, how thick it is. Isn't it looks like a sagittal section of the brain? They say it looks like a brain gyre, right? Look at that. It says there. It looks like a brain gyre, so hypertrophied. It causes excess mucus production with the result of protein loss. These people have protein loss. This particular disease, Menetrius disease, has protein loss. And I want you guys to type it. Why this particular disease has protein loss? Explain. The answer is in front of you, but I want the explanation. Why do this disease has protein loss? Okay, all right. The answer is you need acidity in order to convert pepsinogen to pepsin. Only if you have acidity, you can convert pepsinogen to pepsin, and you need pepsin to protein digestion, isn't it? In this particular disease, there is no acidity. Decreased acid production. That means you cannot convert pepsinogen to pepsin. Is that clear, folks? You cannot. See, it's all physiology from yesterday. You cannot convert pepsinogen to pepsin. No pepsin, no protein. Is everybody clear, folks? You should write it down here. No pepsin, no protein absorption. Okay, that's the idea, folks. Okay, this is precancerous. Patient comes with weight loss, anorexia, vomiting, epigastric pain, edema. Why edema? Because of protein loss. When they lose protein, they get edema, folks, okay? Because all the fluid. We'll talk about that. So that's Menetrius disease. The bottom line, you need to learn why they lose protein, because no pepsin. Is everybody clear? All right.
It's safe to say that you'd also have this in pernicious anemia in that case?
Which one?
In pernicious anemia.
Uh-huh. Yeah, any disease, even not only pernicious, even if they have PPI for a long time. Even if you take, remember, when we take PPI for a month, how come we don't give PPI for a long time? It's usually 9 days or 11 days, most of the time. And we give a break. Then we start again. Because why? If a human takes PPI for a longer time, they don't reabsorb protein. Is everybody clear, folks?
Quick question. So I thought pepsin breaks down protein. So
Yeah, you are right.
So doesn't it break it down to fatty acids and stuff? I think that's why I was lost with protein loss.
All we know is H+. You need acidity environment. You need H+ to convert pepsinogen to pepsin.
Yeah. So does it break down protein or does it absorb? You know what I mean? Because
it breaks down. It's basically break down protein, but you need to break it down in order to absorb.
And to absorb the protein. Got you. Thank you.
Okay. So that's this, folks. Next one, gastric cancer. That's your stomach cancer. Most commonly, gastric adenocarcinoma. They have lymphoma, they have other tumors and stuff, folks. This is early aggressive local spread with no liver metastasis. What they are saying, stomach cancer is something can spread very fast. Okay, it can spread very fast, often presents late with weight loss. Look at the word early satiety. Remember that word I said, anytime you read it, you should suspect something is not right in the stomach. Okay, abdominal pain, obstruction, and some other acanthosis and stuff. There are two types, intestinal type and diffuse type. Intestinal type is associated with H. pylori. Okay, now H. pylori is such a danger infection, folks. You know, people sometimes ignore it. H. pylori infection can easily come, but it is also easy to treat. But if you don't treat it and you leave it in your stomach for more than 2-3 months, you will get stomach cancer. Okay, because of that, H. pylori is one of the infections. We do a test to diagnose. We also do a test after treatment to make sure we eradicate it completely. Is that clear, folks? After the treatment is done, you still have to go do a test and make sure there is no more H. pylori left in your stomach. Okay? And then when it's in the dietary part, right? Smoke food. Which country in the world is #1 for stomach cancer? Japan. Why Japan? Is because smoke food, folks. Okay, that's the idea. Now, tobacco smoking can cause chlorhydria, chronic gastritis. Commonly, it happens in nasal curvature. Okay, so that's your intestinal type. The other type is the diffuse type. That's genetics. Most cases due to ECAD mutations. These are mutations that causing it. The only key is underline this word. In these people, how many people touch stomach in the cadaver? If you remember, it looks so squishy and soft, isn't it, folks? These people's stomach looks like a leather, like a plastic bottle. That's why it says it looks like a 90s plastic. It looks so rough and thick. That's because the whole wall is cancerous, folks. Okay, so that's a diffuse type. That's a diffuse type. So that's your intestinal type and diffuse type. There are two types of stomach cancer. Now, involvement spreading, right? When it comes to spreading, there's a Virchow node, basically involvement of the left supraclavicular node. They are spreading. I want to highlight this guy and this guy. Crooked tumor, very important. Metastasis to ovaries, typically bilateral. So what does that mean? Let me explain this first. You have a stomach here, and you have both ovaries here. Okay. Now, when people have a stomach cancer, that cancer cell spread to the ovaries. So the cancer cell is traveling to ovaries and they are depositing in the ovary. We call that the Krukenberg tumor. Is everybody clear? That doesn't mean patient has ovarian cancer. No ovarian cancer. So you have to understand that one thing. Ovary can have their own cancer, what we call ovarian cancer, or you can have a cancer tissue just spreading there. It's two different conditions. Does that make sense? If I have a cancer from lung, let's say liver, and spread to lungs, does that mean I have a lung cancer? No. So Krukenberg tumor is a stomach cancer just spreading to the ovaries. Is everybody clear, folks? So when we do sample in the ovary, just find those tissues. They do not have ovarian cancer. Please remember that, because when we do large intestine, they get confused with that. Okay. And they would have
it's not considered an ovarian cancer. So it's considered still a tumor, but it's tumor.
Yeah, it's a Krukenberg. Patient has a stomach cancer, it's just spreading ovary. Okay, so that's that. Now, next system area of technology, basically around the metastasis, right? Remember, cancer either spread through the blood or lymph, right? So that's basically it. And then they also have a blemish, basically in digital radical exam, you feel someone in the pouch of Douglas, so it's spreading there also, okay? That's a blemish, we feel the mass during the radical exam, those things. That's spreading. Okay. Now it doesn't matter what type of cancer. Remember, when it goes to lungs, that's where the complication starts, right? So that's something. But by repeat, Krukenberg tumor means spreading in the ovary, no ovarian cancer. Make sure you want this no ovarian cancer. Bilateral, you see that? It's bilateral.
So what would be some over it. Like, can you use like psychology? Do you think they would able to do
So maybe if I take a patient and they had a tumor, if I see their ovary, I will see some gas tissue sitting on top of the ovary.
Okay, right.
Sometimes I would remove the gas tissue, or sometimes I take all over. But if I take the ovary tissue without my microscopy, I would only see the gas tissue. I would not see ovarian cell cancer.
Can it be converted to ovarian?
No. Okay. That's the idea here. So that's gas cancer. Everybody clear? All right. So that's take care of that. Go take a break, and I'm going to start logically.